This case is a 53-year-old woman who presents with early satiety, constitutional symptoms, and then a blood smear that shows anemia and a low white count, as well as thrombocytopenia. Bone marrow examination confirms the diagnosis of primary myelofibrosis, and she has a JAK2 V617F. So the diagnosis is made. This is a patient with primary myelofibrosis, and unfortunately, this is a young woman who now has symptoms. She needs therapy. And the first thing to determine is this patient a stem cell transplant candidate or not? But in addition, one can initiate therapy. There's some missing information here that may be useful in terms of determining prognosis. One, is a karyotype available? Many patients with chronic myeloproliferative disorder, specifically primary myelofibrosis, may have a dry aspirate. That is, you're not going to get a good karyotype. But if one is achieved, it can be very useful in determining stratification in terms of prognosis. Secondly, additional mutations may also be important. Additional driver mutations or other epigenetic mutations that can deter a poorer overall prognosis. Regardless of those two missing facts, this patient has primary myelofibrosis. I typically use the IWG for initial diagnosis. This patient will have an intermediate 2 given her symptoms and anemia. The other one that is often used is the DIPSS score, or DIP score it's often referred to. And this patient again will have intermediate risk because she is anemic and she has constitutional symptoms. She warrants therapy. My initial therapy would be ruxolitinib as I send her for transplant evaluation in order to assess whether or not a good donor can be found. One of the biggest complications with myelofibrosis, especially if left untreated, is that patients can develop progressive abdominal distension, and as a result of that, abdominal pain and early satiety. Once patients develop early satiety, they develop weight loss. Weight loss is a really profound component of disease progression. In addition to that, patients feel poorly. They often have constitutional symptoms that include fever, night sweats, and sometimes pruritus. And there's something called a total treatment score, or TSS, that Dr. Mesa has developed, which can take the symptoms and put it into a numerical calculation. Sometimes as we ask patients questions about how they're feeling, how are they doing, patients may oftentimes underestimate how poorly they are feeling. And this is an opportunity with just a very few number of questions to quantitate it, objectively calculate how poorly patients are feeling. And this can be also used in terms of determining prognosis. The worse a patient is on a total treatment score, the more advanced their disease is. And again, the more treatment initiation with ruxolitinib, which is the only therapy that we have available to us, is indicated. Based on the IWG or the DIPS score, patients are grouped into several classifications: high risk, intermediate 1, intermediate 2, or low risk. It is the intermediate 2 and the high risk patients that have a poorer overall prognosis. And what I mean by that is a very limited time to survival. So these are the patients, specifically young patients like this case represents, that you want to think about allogeneic stem cell transplant. In addition, it's important to ameliorate some of the symptoms that she's experiencing. This patient is having abdominal discomfort, early satiety, and now has weight loss. And if left untreated, she may circle down a pathway that would make her an unsuitable candidate for further therapy.